Is revision otoplasty procedure worth it? I had an ear pinning surgery to bring the ears closer to head last year. Now both ears have completely healed, and I'm unsatisfied with the result, especially the top third of both ears, which stick out excessively due to the absence of helical rim fold. Wondering if any kind of follow-up surgery is available to treat this issue.
Thank you for your question. You submitted a photo and you described in your question that approximately 1 year ago you had otoplasty and that essentially the ears have healed, but you're dissatisfied with the upper third of your ears, and what you describe is the lack of definition of the antihelical fold. And you're asking, can something be done? Well, the short answer is yes. Just to give you a little bit about my background, I'm a board-certified cosmetic surgeon, certified by the American Board of Cosmetic Surgery. I do cosmetic surgery from everything from head to toe, including otoplasty. And I've been in practice in Manhattan and Long Island for over 20 years. So to help you get a perspective of how I approach patients who come for ear consultation and possible otoplasty, it's very important to at least understand the basic anatomy. And I think you've got a very good handle on it just by the way you phrase your question. The issue of prominent ears basically breaks down to three separate areas of the ear. There's the earlobe or the pinna, there is the conchal bowl or the middle third of the ear, and then there's the antihelical fold, which is the upper third. So when the strategy is developed for otoplasty, what we look at each of these areas separately. Now, anyone who performs otoplasty naturally has their preferred method. So I'll share with you my preferred method. So to begin with, let's start with a very common issue, which is the conchal bowl hypertrophy. And also, it's important to also understand that when you look at how close you want the ear to be to the scalp or to the skull, it is typically approximately 1 centimeter from the top to the bottom, with some variation. Now, that being said, very often people can be underdiagnosed, where they may think that they only need the upper third of the ear treated, or maybe a simple pinning of the ears. So this is where there has to be some flexibility. And I explain to my patients that during surgery, I'm continuously evaluating the relative relationships of the way the ear looks as well as the symmetry. So to begin with the conchal bowl, the middle third of the ear, if there is what's called conchal bowl hypertrophy or a enlargement of the cartilage, then my preferred approach is to do a resection or removal of some of the cartilage and then suturing of the cartilage to what's called the mastoid fascia, which is the deeper tissue that's more stiff and allows for the ear to kind of set in. Now, I feel that that's a little bit more effective than suturing techniques where you just pull that part of the ear in. Now, of course, there are ways to do that. Basically, you have to make sure, because cartilage has something called memory. And memory means that if you place stitches, if those stitches kind of get weak or if there is any other loss of tension, then the cartilage goes back to where it started. My logic is when you resect particularly that area, well, then the cartilage is now really changed in a more permanent way than with just suturing. Now, in the upper third, the antihelical fold definition, we do use sutures, but we also first do something where we weaken the cartilage to reduce that memory effect. And those are done with what's called Mustarde sutures, or basically what is to do is to, from the back of the ear, place stitches in a manner which causes the fold to occur, but you don't see anything from the outside or the front of the ear. Now, last but not least is the earlobe. Sometimes the earlobe can stick out a little bit, and so we do a small kind of a skin excision with some tissue excision and bring the earlobe inward. Sometimes otoplasties do need to be tweaked, and in your situation, clearly there is an opportunity to do something about the upper third based on the absence of definition of the antihelical fold. It doesn't mean you have to necessarily go through the whole operation again, but then you can work from behind the ear and recreate the antihelical fold. So I suggest that you meet again with the doctor who did the original surgery and discuss this issue and see if your doctor will be willing to do this revision surgery. As I said, we're dealing with symmetry bilaterally. We're also dealing with trying to get the ideal shape so that it doesn't look so prominent in any part of the ear. And in your case, it's the upper third. So I think meeting with your original doctor and having this discussion and seeing if your doctor is willing to do something about it, then I think that would be the best way. I always feel like the original surgeon has a good sense of how your tissue responded to the surgery and kind of just knows the field a little bit better than somebody who's new, who's starting from scratch. We do a lot of revision surgery, so I understand that perspective, but it's a matter of your relationship with the doctor who did it. If your doctor doesn't want to do something, then of course you'll have to seek another doctor to complete the work until you get the desired result. So I hope that was helpful. I wish you the best of luck, and thank you for your question.